Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we are going to deal about the part 2 of WHO screening of cancer cervix. Right? So in the previous module, we discussed about the see and treat approach, where based on the reports of the primary screening test, you're going to do the treatment. But in this approach, that is the see, triage and treat approach, which is the most commonly preferred approach by the WHO, here we are going to have a primary screening test followed by a triage test, and based on the reports of the primary screening and the triage test, we are going to decide upon the treatment. Right? So here we have three steps, that is the primary screening test and followed by a triage test, and based on the report of the primary screening test and triage test, the treatment is going to be decided. Is that clear? Okay. So here in see, triage and treat approach, we have a primary screening test, and this primary screening test can be either the HPV DNA, which is the most commonly preferred primary screening test in see, triage and treat approach, or you can have the pap smear, which is the cytological study. So either the HPV DNA or the pap smear is the primary screening test. So primary screening test most preferred is HPV DNA followed by pap smear. And we have the triage test. In triage test, we have 4 tests. Please remember all these 4 things. The 4 are HPV genotyping, where we genotype the high-risk subtypes and the other low-risk subtypes as. And then we have visual inspection with acetic acid, and then we have the pap smear and colposcopy. HPV genotyping, visual inspection with acetic acid, pap smear and colposcopy. So all these 4 are the triage test of see, triage and treat approach. And based on the report of the primary screening test and the triage test, that is the see, triage, we are going to decide upon the treatment. And the treatment which we know is the cryoablation and the excisional procedure, such as the large loop excision of the transformation zone or loop electrosurgical excisional procedure. Is that clear? Okay. So the definition of see, triage and treat approach is based on the report of the primary screening test and the triage test. If the primary screening test comes out to be positive and the triage test comes out to be positive, with or without histologically confirmed diagnosis, that is based irrespective of the reports of the histopathological reports, you're going to do the treatment only based on the primary screening test and the triage test. If both tests comes out to be positive, you can do the treatment based on the reports of these both tests. Right? If, let's say for example, if both tests comes out to be negative, you have to rescreen the patient and repeat the test after few years. And that few years is something which is respective to the particular test. Let's say for example, HPV DNA test is repeated after 5 to 10 years in general population, and after 3 to 5 years in HIV positive females. Similarly, pap smear is repeated after 3 years. So with respect to that particular test, the rescreen time will vary. Okay? Yes. But let's say for an instance, if the primary screening test comes out to be positive and the triage test comes out to be negative, what you will do? So if in case the primary screening test comes out to be positive and the triage test comes out to be negative, you have to repeat the positive test. Right? One test has been proved to be negative, but only one test has been proved to be positive. So you need to repeat that positive test. So the primary screening test was HPV DNA testing, which was the most preferred test. So repeat the HPV DNA test. So when you have to repeat it, in general population, you repeat it after 2 years. In the HIV positive patients, you repeat it after 1 year. Is that clear? If both the tests are negative, you just repeat the test after few years, and that is according to that particular test. If one comes out to be positive and the triage comes out to be negative, you repeat the positive test, that is the HPV DNA test, after 2 years in the general population and after 1 year in the HIV positive patients. Is that clear? Okay. So now let's go inside the algorithms which have been proposed in the website of WHO, that is the see, triage and the treat approach. So as we all have discussed, the see, triage and treat approach has primary screening test followed by a triage test. So in all this approach, there is a primary screening test followed by a triage test. So what is the primary screening test? we know that primary screening test or two tests. One is either the pap smear or it can be the HPV DNA testing, where HPV DNA testing is mostly preferred than the pap smear as a primary screening test in TRIAGE and TREAT approach. But in this algorithm 3 of WHO, they have taken pap smear, that is the cytology, as the primary screening test. Is that clear? Okay. So as you can see here, in algorithm 3, primary cytology screening and colposcopy triage. That is, they have taken the pap smear as the primary screening test and colposcopy test as the triage. So let's discuss about the algorithm now. So here, as I told you earlier, the primary screening test was pap smear. So the primary screening test was pap smear, and the reports of pap smear can come out to be either positive or negative. If it is going to be negative, you have to repeat the test after 3 years. Repeat the test after 3 years. If it comes out to be positive, it can be either two things. If it comes out to be atypical squamous cells of unknown significance or something more than the atypical squamous cells of unknown significance. Which is more than atypical squamous cells of unknown significance? The low-grade squamous intraepithelial lesion, the high-grade squamous intraepithelial lesion, the atypical squamous cells where HSCL cannot be ruled out. So all these are more than the atypical squamous cells of unknown significance. If it is equal to atypical squamous cells of unknown significance, you follow the pap smear with the triage test as HPV test, right? If the report of pap smear is only atypical squamous cells of unknown significance, you follow the pap smear with the triage test of HPV DNA test. So the HPV DNA test can come out to be either positive or negative. If it comes out to be negative, you're going to repeat the test of pap smear after 3 years, because HPV comes out to be negative, but only pap smear is positive as atypical squamous cells of unknown significance. And as I told you, if the primary screening test comes out to be positive and the triage test comes out to be negative, repeat the positive test. So the positive test here is pap smear. So repeat the pap smear after 3 years. So after 3 years, we are going to repeat the test. If the report comes out to be negative, what are you going to do? If the report comes out to be negative, you have to repeat the pap smear again after 3 years. But if the report comes out to be positive, something more than atypical squamous cells of unknown significance, what you will do? So anything more than atypical squamous cells of unknown significance, let's say low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, atypical squamous cells where HSCL cannot be ruled out, in that cases you have to follow up with the triage test of colposcopy, right? You have to follow up with the triage test of colposcopy. So colposcopy, we know that it is a magnifying instrument through which we can take biopsy from the abnormal looking cervix and send it for histopathological examination. So always remember, anything which is equal to atypical squamous cells of unknown significance, the triage test is going to be HPV DNA. Anything more than atypical squamous cells of unknown significance, the triage test is going to be colposcopy. So here, if the report comes out to be more than atypical squamous cells of unknown significance, you have to repeat the triage test with colposcopy. Or if the HPV DNA test also is positive and the primary screening test is also positive, you have to follow it with the colposcopy, right? The pap smear report comes out to be atypical squamous cells of unknown significance and the HPV triage test comes out to be positive. Now you have to follow up with the triage test of colposcopy. Is that clear? Anything equal to atypical squamous cells of unknown significance, keep the triage as HPV DNA. HPV DNA can be either negative or it can be positive. If it is positive, follow up it with the triage test of colposcopy. If it is negative, just repeat the test. Is that clear? Yes. And based on the reports of colposcopy, based on the reports and the histopathological diagnosis, you are going to manage the patient. So this is the algorithm 3 of WHO TRIAGE and TREAT approach. Good. So please take a screenshot so that it will be much easier for you to revise for your exams. Right? Okay. So in algorithm 4, they have given HPV DNA screening and HPV 16-18 triage. So HPV DNA test screening is actually the primary screening test. And HPV 16/18, which is actually the HPV genotyping, is the TRIAGE test. So once you do the HPV DNA test, the reports can be either negative or positive. If it is going to be negative, repeat the HPV DNA testing after 5 to 10 years in general population and after 3 to 5 years in HIV positive females. Clear? Okay. But if it comes out to be positive, you follow up the primary screening test of HPV DNA testing with the TRIAGE test of HPV genotyping. And in HPV genotyping, the reports can be either the high-risk subtypes such as the HPV 16 and 18, or it can be other high-risk HPV subtypes. But if the report comes out to be HPV 16 and 18 positive, now you have done the primary screening test and it is positive, and the TRIAGE test, that is the HPV genotyping, HPV 16 and 18, that is also positive. Now you have to do the treatment based on the report of the primary and the TRIAGE test. So you have to consider the indications for ablative treatment being present in that patient. If the indications for ablative treatment is met, you go for the ablative treatment, such as the cryoablation. If the criteria for the ablation is not met, you can go with the excisional procedure such as the large loop excision of the transformation zone or loop electrosurgical excisional procedure. Right? Okay. Or in case of any suspicion of cancer, any suspicious cancer, you have to go with further evaluation, biopsy, and based on the reports of biopsy, you go for the management. And for large loop excision of the transformation zone, you will be left with some tissue specimen, right? You're going to subject it for histopathological examination, and the histopathologist can provide the report as either invasive cancer or it is just the dysplasia which has been limited to the particular segments of the cervix. So if it is a dysplasia which is limited to CIN less than CIN3 or less than CIN3 or less than adenocarcinoma in situ, it is well and good. You have done the treatment as large loop excision of the transformation zone. So just keep the patient in follow-up. So ask the patient to come for follow-up after 1 year. But if it comes out to be an invasive cancer or a cancer based on the report of LLETZ, if the report comes out to be cancer being present, follow up it with proper biopsy and management. Clear? Okay. But if the HPV genotyping TRIAGE test comes out to be any other subtypes other than the HPV 16 and 18, you have to follow up it with the VIA triage, visual inspection with acetic acid triage. So here the primary screening test was HPV DNA testing and the TRIAGE test was HPV genotyping, and here for other high risk HPV subtypes, the TRIAGE test was visual inspection with acetic acid, which we will be discussing in the next algorithm. So algorithm 4 was all about HPV DNA testing as the primary screening test and HPV genotyping as the TRIAGE test. Now we have the algorithm 5. In algorithm 5, the primary screening test is again HPV DNA testing. Right? Okay. So as we discussed in the algorithm 4, if it comes out to be negative, you repeat after 5 to 10 years in the general population and after 3 to 5 years in HIV positive females. But if it comes out to be positive, if the HPV DNA testing as the primary screening test comes out to be positive, you are going to take here in this algorithm the TRIAGE test as visual inspection with acetic acid. In algorithm 4, you had the TRIAGE test as HPV genotyping. Here you have the TRIAGE test as visual inspection with acetic acid. So the reports can either be positive, negative, or suspicion of cancer. Any cases of suspected cancer, you go for further evaluation, biopsy, and based on the reports of biopsy, the further management for the patient will be decided. If it comes out to be negative, you repeat the HPV test after 2 years for general population and after 1 year for HIV positive patients, because the primary screening test is positive. But VIA-SS TRIAGE test comes out to be negative. If primary screening comes out to be positive and triage test comes out to be negative, you have to repeat the positive test. So here the positive test is HPV DNA. So repeat HPV DNA after 2 years in general population, after 1 year in the HIV positive females. So if the VIA comes out to be positive, you consider, since the primary screening test is positive and the VIA is also positive, you can consider treatment based on the report of the primary screening test and the TRIAGE test. So consider the eligibility for ablation. If it is met, do the ablative treatment. If it is not met, consider excisional procedure, and in excisional procedure you will be left off with the tissue sample, subject it for histopathological examination. The report can either be as cancer or anything, dysplasia which has been less than, adenocarcinoma in situ less than, cervical intraepithelial neoplasia type 3. It is well and good that you have done the treatment already, so just keep the patient and follow up after 1 year. If it comes out to be cancer, you just follow up it with the biopsy, and based on the reports of biopsy, manage the patient further. Right? So this was all about the algorithm 5. Now we are going to the algorithm 6. In algorithm 6, the primary screening test is again HPV DNA testing. So as we all know, if the report of HPV DNA testing as the primary screening test comes out to be negative, you repeat the test after 5 to 10 years in the general population, after 3 to 5 years in HIV positive females. If it comes out to be positive, follow up it with the TRIAGE test. In algorithm 4, we had the TRIAGE test as HPV genotyping. In algorithm 5, we had the TRIAGE test as visual inspection with acetic acid. In algorithm 6, we have the TRIAGE test as colposcopy. Right, colposcopy. So based on the report of colposcopy, that is the histopathological diagnosis, you will further decide upon the treatment options. Right, so this is all about algorithm 6. So now I'm moving on to the algorithm 7. In algorithm 7, we have the primary screening test as again HPV DNA testing, which is the most preferred test by the WHO as the primary screening test in see, triage and treat approach. If it is negative, repeat it after 5 to 10 years in general population, 3 to 5 years in HIV positive females. If it comes out to be positive, and in algorithm 7, they are taking the triage test as pap smear. If the pap smear comes out to be negative, what are you going to do? If the pap smear comes out to be negative, here the primary screening test is positive and the pap smear, the triage test is negative. So here you have to repeat the positive test. So repeat the HPV DNA testing after 2 years in general population, after 1 year in HIV positive females. So once you repeat it after 2 years in general and after 1 year in HIV positive female, the reports can be either negative or positive. If it is negative, you can just follow up the patient. You can rescreen them with HPV testing after 5 to 10 years as in every other general females. But if it comes out to be positive, what are you going to do? So please remember that anytime you do the pap smear, if the reports of the pap smear comes out to be anything more than atypical squamous cells of unknown significance, you have to follow up with colposcopy. So here if it comes out to be positive, we have to repeat it with colposcopy, and based on the reports of colposcopy, the further treatment plan will be decided upon. Right? So here the simple thing which I can give you here is we have discussed in C, triage treat approach. In C, triage and treat approach, right? In C, triage and treat approach, we have algorithm 3, 4, 5, 6 and 7. 1 and 2 was C and treat approach. 3, 4, 5, 6, 7 of WHO is all about the C, triage and treat approach. So in 3, the primary screening test was what? The triage test was what? So in 3, the primary screening test was pap smear. And the triage test was what? HPV DNA and colposcopy was done. Right? In 4, 5, 6, 7. All the 4, 5, 6 and 7 we had HPV DNA testing. Right? We had HPV DNA testing as the primary screening test, right? Yes. Right, so we had algorithm 4, 5, 6 and 7. In 4, the triage test which was taken was HPV genotyping. In 5, the triage test which was taken was visual inspection with acetic acid. In 6, it was colposcopy, and in 7, it was pap smear. Sorry, I have just... Now, is that clear for you? Yes. So the WHO algorithm which has been released for the see, triage and treat approach was 3, 4, 5, 6 and 7. The primary screening test was pap smear. 4, 5, 6, 7, the primary screening test was HPV DNA testing, which is the most preferred primary screening test in see, triage and treat approach. The triage test was HPV DNA or the colposcopy in third algorithm, and in fourth algorithm with HPV DNA we had HPV genotyping, and in fifth algorithm along with HPV DNA we had visual inspection with acetic acid as the triage test, and in sixth algorithm we had HPV DNA testing along with the colposcopy as the triage test, and in seventh algorithm we had HPV DNA testing along with the pap smear as the triage test. So as I told you, pap smear and HPV are the primary screening test, and HPV genotyping, visual inspection with acetic acid, colposcopy and pap smear are the triage test. So 3, 4, 5, 6, 7, all these are the algorithms which are being released by the WHO in see, triage and treat approach. So the see, triage and treat approach is much effective and much preferred by the WHO than the see and treat approach. Because in see, triage and treat approach, you're going to do a series of tests, and only based on the reports of the series of tests, you plan the treatment. Whereas in see and treat approach, based on the report of only one test, you're going to do the treatment. Is that clear? Yes. So this was all about the see, triage and treat approach, which was given by the WHO. So if you ask me, this is more important than the see and treat approach. So in the next module, we'll be discussing with another interesting topic. So let's meet in the next module.